This is the Irish guideline, venous thromboprophylaxis in pregnancy. Let's start with the SBA. 38-year-old para-zero woman attend for an elective cesarean section for breech presentation. Her BMI is 32. Her mother and sister have both had a DVT in the past. Post-operatively, she developed a swollen left leg and shortness of breath. On examination, the leg is blue with the evidence of varicose vein bilaterally. The left leg is painful to move. What is the most appropriate next management step? A. Arrange a ventilation perfusion scan. B. Arrange a leg Doppler. C. Commence prophylactic glycine. D. Commence therapeutic glycine. E. Encourage the use of TAD until further investigation. The correct answer is commence therapeutic glycine. Venous thromboembolism (VTE) remains a leading cause of maternal mortality and morbidity. Although the absolute risk is very low, less than 1 per thousand delivery, the highest risk of VT in the postpartum is in the postpartum period. But it must be remembered that VTE related death occur in all three trimesters of pregnancy. Low molecular weight heparin are the anticoagulant of choice for thromboprophylaxis in pregnancy, and there is now considerable experience of their use in pregnancy. Preconceptual assessment. Women at risk of VT should ideally have a preconceptual assessment to outline the management plan for their pregnancy. Association have been described between inherited thrombophilia and VTE and between inherited thrombophilia and common pathology in pregnancy like PET, IUGR, placental abruption, and stillbirth. The strength of these association is weak. Obese pregnant women who are at or who are hospitalized are at a particular risk of VTE. Although age, parity, and obesity are worthy of particular focus, but obesity in particular has been highlighted in recent confidential inquiries. Pregnant women should have a documented risk assessment for VTE at their booking visit, and VTE risk should be reassessed at each and every episode of hospitalization, after delivery, and on discharge. We already discussed the highest risk of VTs in the postpartum period, but it must be remembered that VTE related death occur in all three trimesters. Women with a past history of VTE. This is very important point. Women with a past history of VTE plus women who have a VTE related to estrogen or progesterone should receive VTE prophylaxis antenatally as well as postpartum for 6 weeks. But they are excluding those women who have a single episode of VTE provoked by a transient risk factor not related to estrogen or progesterone. So VTE related to estrogen or progesterone, those women should receive antenatal VTE prophylaxis as well as postpartum VTE prophylaxis. But except those with a single episode of VT provoked by a transient factor should receive only antenatal surveillance and postpartum prophylaxis 6 weeks. So antenatally they should have a surveillance only. This point is also clearly mentioned here. Women with a past personal history of VTE are identified. These women should be offered both antenatal and postnatal low molecular weight heparin thromboprophylaxis. The only exception would be in a woman with a previous personal history of VTE with clearly identifiable major transient risk factor that is no longer present, who have no other risk factor. Such women can be offered surveillance antenatally followed by postpartum thromboprophylaxis. The second stage of this approach identify women who have at least 3 risk factors. On this basis should be considered for LMWH thromboprophylaxis. A personal history of previous VT is the most potent risk factor for VT in pregnancy. It is now broadly accepted that if the previous VT was provoked by a major transient risk factor, then the risk of recurrence antenatally is low compared with other subgroup. Thus, with this exception, all women with the previous VT should receive antenatal and postpartum thromboprophylaxis. With women with a common inherited thrombophilia and a history of VT will usually manage based on clinical history. So LMWH is the anticoagulant of choice. Oral direct thrombin inhibitor are not recommended. Fondaparinux and intravenous direct thrombin inhibitor should be limited to women with severe allergic reaction to heparin and should only be prescribed by a specialist in obstetrical hematology. Compared with unfractionated heparin, LMWH show a more predictive dose-response curve and do not require regular monitoring and have a significantly better side effect profile in terms of heparin-induced thrombocytopenia or osteoporosis. Evidence suggests that activation of coagulation system starts early in pregnancy and thrombin generation is increased within the first trimester compared with the pre-pregnancy. So women who are advised to take antenatal LMWH thromboprophylaxis should commence as soon as the pregnancy has been confirmed. And they are also advising early pregnancy scan in women receiving LMWH thromboprophylaxis to ensure the presence of intrauterine pregnancy. So when prescribing low molecular weight heparin at a prophylactic dose once a day dosing is reasonable and there is no need for routine anti-10A monitoring. If the initial platelet count and the renal function are normal, a weight-adjusted regime should be used. Anti-10A monitoring is not recommended except with extreme body weight, renal impairment, severe preeclampsia, and additional advice should be sought from the hematology. Mechanism of low molecular weight heparin, it bind it bind less It binds less to the plasma protein. Most LMWH preparation have a longer plasma half-life due to the lower incidence of binding to the macrophages and endothelial cells. Thus, longer bioavailability make it possible for once daily treatment. Thromboprophylaxis in the third trimester. So timing of LMWH administration should be confirmed with the woman. Early morning injection is recommended. All women should be provided with education on the symptoms of labor and instructed not to take their injection if the labor commences. All women should be reminded of the importance of the postpartum thromboprophylaxis. Management of labor and delivery should be in accordance with usual obstetric indication. There is no contraindication to spontaneous labor. This is very again important point. Regional anesthesia, epidural regional anesthesia administered. So women receiving a prophylactic dose of low molecular weight heparin should not have an epidural or regional anesthesia administered until 12 hours after the previous dose, assuming normal renal function. So, women who receive a prophylactic dose should not have an epidural or regional anesthesia administered until 12 hours after the previous dose. Again, the second important point, women receiving a prophylactic dose of low molecular weight heparin should not have a regional anesthesia administered, as we discussed, and not have an epidural catheter removed until 12 after the previous dose, assuming normal renal function. The third important point, prophylactic dose of low molecular weight heparin may be commenced not less than 6 hours post removal of epidural catheter or administered of spinal anesthesia. This is very important point. Let's do another SPA. Your hospital has introduced enhanced recovery in gynecology, which aim to facilitate a rapid recovery and return to normal activity following elective gynecological surgery. What is the key management in ER? A. Avoidance of intraoperative hypothermia. B. Consumption of carbohydrate drink in perioperative period. C. Early feeding. D. Early mobilization. E. Reducing intravenous fluid volume. Correct answer is early mobilization is the key to enhanced recovery. All women who have an emergency cesarean section should receive thromboprophylaxis until discharge. This is very important point. Who have an emergency cesarean section and if she is low risk, then she should receive thromboprophylaxis only until discharge. Or if she is high risk or additional risk factor of VT is present, then we can give her for a longer time period. It is reasonable for all women who have undergone elective cesarean section to be considered for thromboprophylaxis while in hospital, as the benefit of LMWH may outweigh the risk. Thromboprophylaxis is commonly prescribed after an elective cesarean section. It is reasonable to consider commencing LMWH in women post-elective cesarean section even in a low-risk setting. Postpartum thromboprophylaxis. Every woman should have a repeat VT risk assessment after delivery. All women who receive antenatal LMWH thromboprophylaxis should continue on the treatment for at least 6 weeks postpartum. Second important point, this is first important point, that all women who receive antenatal thromboprophylaxis should have a continued treatment for at least 6 weeks postpartum. Second important point is women with a documented thrombophilia with no previous personal history of VT but a positive family of history of VT should be considered for postpartum thromboprophylaxis for at least 6 weeks. The third important point in this slide is if low molecular weight heparin thromboprophylaxis is indicated postpartum, it should be given until the woman is fully ambulant. This will usually coincide with discharge from the hospital. There is no evidence to guide the optimal length of postpartum thromboprophylaxis. It is not clear what the additional benefit in extending thromboprophylaxis up to 7 days post delivery. So, thromboprophylaxis beyond discharge from hospital need only be offered to women at high risk of VT. Now we will do another SBA. 40-year-old lady was admitted with pelvic mass, ascites and shortness of breath. At laparotomy, she was found to have a solid ovarian tumor, the result of which was benign. What is the most likely cause of her shortness of breath? A. Pulmonary edema, B. Pulmonary embolus, C. Pneumonia, D. Pleural effusion, E. Myocardial infarction. The answer is pleural effusion. She has a Meeks syndrome. You can see here the pelvic mass, ascites and shortness of breath with a solid ovarian tumor. So this is triad of solid benign tumor, ascites and pleural effusion for the Meeks syndrome typically present with this. Breastfeeding and anticoagulation. Both are suitable, warfarin and NMWH for use during breastfeeding, but warfarin has added disadvantage of increased risk of postpartum hemorrhage and perineal hematoma with the warfarin. Women on lifelong anticoagulant. Women on lifelong anticoagulant need highly specialized management with hematology and obstetric input. These women should have a preconceptional counseling. These women may be switched to low molecular weight heparin for preconceptional period or change from warfarin to LMWH after the diagnosis of pregnancy within 6 weeks of conception. Another important point, women on lifelong anticoagulant. For most of these women, anticoagulant can be achieved with a therapeutic low molecular weight heparin dosing, and this may be converted to prophylactic low molecular weight heparin dose at term so that the risk of delivering while therapeutically anticoagulant is diminished. In women with high risk of thrombosis, consideration may need to give given to a planned induction of labor. Planned induction of labor to minimize the time the patient is not therapeutically anticoagulated. Prophylactic low molecular weight heparin should be given at least at 6 hours post delivery. So at 6 hours post delivery, those women should receive prophylactic low molecular weight heparin, and these women should increase to therapeutic anticoagulant at 24-hour post delivery, assuming there is no excessive bleeding. If there is no excessive bleeding, we can convert at only 24-hour post delivery. Before that, she have to receive the prophylactic dose. This is very, very important point. Let's do the another SPA. 35-year-old woman was in labor in her first pregnancy. She has made slow progress and had been on centosanol for the last 12 hours. She was having an emergency cesarean section for failure to progress when she collapsed on the table. What is the most likely diagnosis? A. Pulmonary infarction, B. Aortic dissection, C. Pulmonary embolism, D. Amniotic fluid embolism, E. Aortic rupture. Answer is amniotic fluid embolism. This we already discussed. Let's do the another SPA. 75-year-old woman had a vaginal hysterectomy for pelvic organ prolapse. She woke up feeling short of breath in the morning on post-operative day 1. There are crackles on oscillation bisally. Options are A. Pulmonary edema, B. Pulmonary embolus, C. Pneumonia, D. Pleural effusion, E. Myocardial infarction. Answer is pulmonary edema. Women with class 3 obesity. Women with a class 3 obesity is reasonable to start thromboprophylaxis in women with class 3 obesity, BMI greater than 40 during hospital admission. It is reasonable to use weight adjusted LMWH dosing in all women with obesity. And the important point is this: we have to monitor anti-10A monitoring in this group of women is maybe of value. Women with recurrent miscarriage who have proven antiphospholipid antibodies should be given prophylactically low molecular weight heparin and low dose aspirin. In women with recurrent miscarriage without antiphospholipid antibody, there is insufficient evidence to recommend LMWH. Women with a history of placental mediated pregnancy complication. Women with a history of early hypertensive disorder or fetal growth restriction should be considered for inherited thrombophilia testing and low molecular weight heparin if testing is positive, and these women should also receive heparin. For all other women with a history of pregnancy complication, there is insufficient evidence to recommend thrombophilia screening or thromboprophylaxis at the present time. Indication for thrombophilia testing. Thrombophilia testing may be indicated in for asymptomatic women with a family history of VT first degree relative if the event was unprovoked, pregnancy or OCP related or associated with the known familial thrombophilia, women with a history of provoked VTE if the provoking risk factor was mild or the effect of the risk factor is unknown. Thrombophilia testing is not indicated in the following: women for whom the clinical risk assessment alone already recommend thromboprophylaxis, means those women who have a previous unprovoked VTE, estrogen related VTE, history of recurrent VTE, women with a history of VTE due to the major provoking risk factor which is no longer present, Women who have asymptomatic relatives with factor 5 latent or prothrombin gene polymorphism, asymptomatic before assisted conception or with ovarian hyperstimulation, or at the time of acute thrombosis or while on anticoagulant therapy. These women should not have a thrombophilia testing. Should the risk and the benefit of the testing can be clearly explained to the women. Rapid risk assessment tool for VT in pregnancy. Women with a personal history of VT, as we already discussed, women with a personal history of VT, antenatal prophylaxis, and postnatal prophylaxis, and refer to combined obstetrical hematological care. Women with a 3 or more risk factor consider low molecular weight heparin thromboprophylaxis. So these are the risk factors. Family history, BMI greater than 30, maternal age greater than 35, and parity greater than 3, smoking, varicose vein, paraplegia, hematological condition, sickle cell disease, polycythemia, essential thrombocythemia, or myeloproliferative disorder, nephrotic syndrome, intravenous drug user, inflammatory bowel disease, and other relevant risk factor. Women with 3 or more of the above risk factors should receive LMWH thromboprophylaxis. Other transient risk factors are hospital admission or postpartum, surgery in pregnancy or puerperal, hyperemesis, dehydration, ovarian hyperstimulation syndrome, systemic infection, immobility greater than 4 days bed rest, preeclampsia, excessive blood loss greater than 1 liter or blood transfusion, multiple pregnancy, assisted reproduction, and postpartum wound infection. This is the whole chart given for the rapid risk assessment tool for VT in pregnancy. So, thromboprophylaxis regime in pregnancy for women with mechanical heart valves. This woman should have a preconceptual counseling, and these women should conversion of to low molecular weight heparin from warfarin as soon as the pregnancy is confirmed. Then we can give the therapeutic low molecular weight heparin in a BD dosing with peak anti-10A level adjusted, or warfarin from 13 weeks until late third trimester. If on warfarin, switch to low molecular weight heparin at 34 to 36 week. Switch to intravenous unfractionated heparin infusion before planned induction and stop once labor commences or 4 to 6 hours prior to planned LACS cesarean section. Recommends unfractionated heparin or prophylactic low molecular weight heparin 4 to 6 hours post delivery. So prophylactic or unfractionated heparin is recommended 4 to 6 hours post delivery or prophylactic. Then therapeutic low molecular weight heparin should not be recommended until at least 24 hours after delivery, and warfarin may be recommended after 48 hours but with need close monitoring to maintain safe therapeutic range. Therapeutic LMWH should be continued until INR is within therapeutic range. This is the whole chart regime for women with mechanical heart valves. This is a dosing. The very important dosing is women with 50 to 90 kg, and these questions are also coming sometimes in the exam or recalls. They should receive tinzaprine 4500 unit daily. Other weight related doses we should memorize. So RCPI, important point, let's discuss. Thrombophilia positive, Thrombophilia positive plus family history positive and no personal history. Do antenatal surveillance and consider LMWH 6 weeks postpartum. If patient on antenatal thromboprophylaxis, low molecular weight heparin thromboprophylaxis, give postnatal low molecular weight heparin thromboprophylaxis for 6 weeks. Postnatal low risk. If postnatal we are giving low molecular weight heparin and if she is low risk, until discharge is recommended. Postnatal high risk for 7 days is recommended. Past history of VTE with transient risk factor, consider postnatal only. Emergency LACS offer low molecular weight heparin until discharge and elective cesarean section consider low molecular weight heparin until discharge. Let's do another SPA. A 44-year-old woman with no past medical history is undergoing laparoscopic hysterectomy for heavy menstrual bleeding. When considering venous thromboembolism prophylaxis in the immediate postpartum period, which of the following statement is most accurate? Both LMWH and unfractionated heparin reduce the incidence of wound hematoma. B. Intermittent pneumatic compression is not as effective as heparin in the prevention of asymptomatic DVT. C. There is no difference between unfractionated heparin and low molecular weight heparin in prevention of DVT. D. There is no differences between unfractionated heparin and low molecular weight heparin in reducing bleeding complication. E. There is no difference between unfractionated heparin and low molecular weight heparin in reducing fetal PE. The correct answer is there is no difference between low molecular weight heparin and unfractionated heparin in the prevention of DVT. So this is the talk article I have added in this presentation as well. A review of stroke in pregnancy and management. Let's do it fastly. Stroke is defined as a neurological episode attributed to acute focal injury of the central nervous system by a vascular cause including cerebral infarction, cerebral vein thrombosis, and intracranial hemorrhage and subarachnoid hemorrhage as the leading cause of death, second leading cause of death, and third leading cause of adult disability. This is the picture. Let's discuss the important symptoms. How to recognize symptoms of stroke. Face drooping, arm weakness, speech difficulty, time to call. This is the fast campaign outlining how to recognize symptom of stroke. Important point. How to diagnose. In most cases, non-contrast computed tomography (CT) will provide the necessary information to make decision about acute management such as intravenous thrombolysis. ICH is contraindication to thrombolysis. Another important point. CT angiogram has a high diagnostic value in detecting high degree of cerebral arterial stenosis, whereas CT perfusion provide high specificity in detecting infarction and ischemia of the brain tissue. This is very important point. In pregnancy, if patient is pregnant, imaging should be done promptly to allow early treatment and optimize outcome. MRI is the preferred first line imaging modality in pregnancy, but it does not expose the pregnant woman because it does not expose the pregnant woman to radiation. This is the same point here also given. MRI is the preferred first line imaging modality in pregnancy. So these are the investigation according to the risk factors. Contraindication to thrombolysis is given here. Post-stroke thrombolysis care. Mode of delivery is safer to go for a vaginal delivery. So anticoagulant should be continued for at least 6 weeks postpartum. Let's do another SPA. 62-year-old woman with a raised BMI had a laparotomy to remove a solid ovarian mass. She has been reluctant to mobilize due to occasional cramping pain in her leg. On post-operative day 3, she complained of chest pain and difficult breathing. What is the diagnosis? A. Pulmonary edema, B. Pulmonary embolus, C. Pneumonia, D. Pleural effusion, E. Myocardial infarction. The correct answer is pulmonary embolus. Cough pain can be presentation of a DVT. Thank you so much.